Yes. Good evening, friends. I think we are already 27 to 30 who have joined. Welcome you all for this year's first meeting of Inform. Last meeting we had to skip because it was very close to the national conference, and we were all busy. And not only busy, we were just returned. And it was a great thing that ISN, Indian Society of Nephrology, got interested in intervention nephrology workshops, and it was a big hit, and it went on so well. And I think there should have been a lot of appreciations because um, our ISN president secretary called and already is getting ready for the next Cochin meeting where they want a similar workshop for you know intervention nephrology. So I'm happy that interventional nephrology is picking up so well in our country. And when you think of it, it was only a few years. You know, all these great things have happened in last few years only. And after COVID, when we all started meeting in virtually and in WhatsApps, and how quickly that can make people learn and start doing procedures was, I think, it was a new finding and a new learning for all of us, because we always think we need big campuses and great facilities and teachers and programs to really push in people into new areas, but newer tools have made this so easy. And one proof is our interventional nephrology. To tell you the fact, I myself was doing interventions like AVF and catheters and renal artery intervention, but I wasn't doing AV fistula interventions until we all started meeting in these forums and started discussing with each other and getting confidence from and guidance from colleagues and friends who were very much involved in these forums. So this meeting, I was wondering what to discuss about. Then I came across this posting by Deepak, that two of the students had finished their training, and he had come back and he has started doing plasties, and his first case, and I think that was what he had reported. That gave me this idea. Why not discuss about this fellowship programs and how people get into it and how easy or how difficult it was, and also bring in the trainers who are involved in teaching these fellows from centers like SGPGI, Girish Center, and Hardik, and all these trainers who were involved in this, and their experiences of how difficult or easy was it to train these newcomers who probably had no exposure to any of these interventions, and how motivated they were and all that. So I thought we'll have a meeting like that. And of course, the core uh, talk I thought will be by somebody who was a beginner to start with, uh, in this program, and who has become a trainer by himself, and who is going to talk on complications and I mean, from beginner steps to tackling challenges. He's going to talk on tackling challenges in managing AV fistuloplasties and complications. So this will be two presentations. One will be a short case presentation by Dr. Deepak Kumar, was just returned from his fellowship, and that will be followed up with by Dr. Hemant, who will be informing us about the possible complications and methods to come over these complications. And we have Vineet with us, and Vineet, like a lone man fighting, he has been concentrating on PD, and he's doing a great job trying people and getting them motivated. So resurrecting the role of, I mean, the place of PD itself in our practice. And Vineet,
Yes, sir. So will you share your slide, sir?
yeah, yes, Vineet.
So are you sharing your slides?
Oh, it's not being shared, is it? You don't see?
No, sir.
Oh, so all this while I thought,
It is visible, sir. It is visible.
Yes, sir.
one minute. Because stop share, it says,
Yeah, it was visible. It was visible.
But how can I not see your slide, sir? Yeah, saw it, sir. Got it, sir. Got it. Now you can see it, sir.
You can go full screen now, sir.
Yeah, I can see it now, sir. Good evening, everyone. Welcome to the first Inform session of 2026. And after that wonderful introduction by Sir, we have one of our intervention nephrologists doing his maiden presentations in Inform, Dr. Deepak Kumar Selvanathan, who is presently working as the consultant nephrologist at Kamakshi Memorial Hospital, Chennai. And he after doing his DM and DNB in nephrology, he went on from Madras Medical College, Chennai. He went on to work in Kilpauk Medical College, a short stint at Madras Medical College. Subsequently, did his training in intervention nephrology fellowship at Singapore General Hospital with Dr. Tan, and presently is working as intervention nephrologist at Kamakshi Memorial Hospital. Looking forward to his first session. And our second speaker, Dr. Hemant, is new in the field of intervention nephrology, but he has already become a trainer, experienced trainer, and he needs no introduction. Has been presenting here quite often, and he did his initial DM and DM in nephrology, and did his post doctoral fellowship in interventions from SGPGI Lucknow about a couple of years back, and presently is working in Manipal Hospitals, Bangalore, as consultant nephrologist and intervention nephrologist. He has multiple publications and has presented and has been a trainer and faculty in several conferences, presenting talks and participating in workshops. So with this, we'll ask the speakers to share their slides. I request Dr. Deepak to first share his slide,
Yeah,
and
yes,
after
sir.
that, we can...
Is it visible, sir?
Yeah, it's visible.
Okay, okay, sir. Okay. So thank you, sir, for the kind presentation. Shall I start, sir?
Yes, please, please.
Just sharing my experience of one initial case which I came across. So she's a 79-year-old lady who is on dialysis with us for the
Deepak,
past. Sir,
Deepak, I think a few words about how you got into
yeah,
training.
uh,
I think we are
yes, sir.
not seeing
Actually,
your slide set. Have you shared?
yeah, it's shared, sir. Are you able to
It's
see?
visible, sir.
Visible, okay. So, sir, actually, I had this interest in intervention during residency, and frequently I used to see the Inform lectures very often. And when I was doing my associate consultancy in Madras Medical Mission, that is where I had the help of my colleague, the Dr. Rajiva, and she pushed me to apply this intervention at that time. And I was learning a bit of a good amount of PD exposure in Triple M. So that is the time I applied for the fellowship. I applied in 2022 actually, and there was some change in the centers, and I got to start my training the last year 2025. So there was a bit of delay in that, and then the process of application and getting clearance from Singapore, the visa and all took around 8 months. So I started my preparation in 2024 and August, and was able to enter into the country in 2025 August. So I did my training for nearly now 4 months there actually. and then I came back in December last year. So, so basic application was initially I applied through ISN website and first contacted the center. So initial center was in Japan actually, under the Kakaikai Central Clinic. So that was actually closed down. So I was supposed to go in 2023, and then the centers changed, and then I opted for Singapore Hospital, and then I got to go this year after 3 years of waiting. Yeah. So
Yeah,
yes, sir.
as you said, when initially all of us had to depend on such programs outside the country.
Mm,
Where Girish, Manas, Venki, all going out to Korea, US, and places like that. And I think now we have enough and more training opportunities in our country itself.
yeah.
Is that isn't it right?
Uh, yes, sir. Actually, I applied in 2022. So the ISN actually granted me permission to start the training, but there was some center issues, and then I had to wait for some time to get it. So that was the major
Have
reason.
you given hands-on thing all the
Yeah.
4 months?
Sir, hands-on in the center, there are like 4 to 5 cases per day. Majorly used to be thrombectomy procedures, sir. So around two thrombectomies and plasties, around three used to be there per day. So it is actually a team there. Dr. Tan is the head of department in nephro there, and there are around four consultants there who actually train us. So Dr. Pang and Dr. Alvin and Dr. Chivu and one more, yeah, and Dr. Milo. The Dr. Tan also used to come, and then assist teachers also. So it was a combined learning, and also we used to get posted along with the IR team and also with the vascular team. So the INS, which is called the Interventional Nephrology Suite, is actually shared by the three departments. So like from Monday to Saturday, we used to have 2 days by IR, 2 days by vascular, and 2 days by nephro. So we used to get exposed to techniques by IR also, and by the some amount of open vascular techniques by vascular team also, sir. So and
Girish,
sir.
Girish,
Yes, sir.
yeah, you should be a happy man because the group of students you trained in the first and second batch, I think they are populating the scene in all over the country. And now most of the workshops, I think we see our boys getting engaged. Even in the ESN, uh,
Yes, sir.
the performers were mostly from this era who got trained amongst our centers in the country.
Absolutely, sir. I think it's really heartening to see the way we have progressed. I think it's been an exponential growth in the last 3, 4 years, I would say. And I think Inform had played a huge role. So if we have to remember the days where Venki sir, me and Shabaz, all of us went abroad, and we were not sure till we stepped into the department that we would get trained and we would get hands-on training. Uh, but yeah, I mean, thanks to the efforts of pioneers like you today, I think every year we are sending nine interventional nephrologists. We are adding nine interventional nephrologists to school, sir, as of today. And only one word I would like to add is that. The most important thing is that the branch is growing. It is also important for us to consolidate what we have achieved till date. Like, when we are doing interventions, they say it is very important to retain the access, preserving the guide wire. Similarly, whatever uh, gains we have made till date in interventional nephrology, that needs to be consolidated.
Mm.
And for doing that, one is we have to get all these courses recognized by National Medical Council. I think we all have to look in that direction as well, because just like interventional nephrology is growing, the number of vascular surgeons, the number of interventional radiologists, they are also growing. And whether we like it or not, at some point of time, even though everyone has their own work to do, at some point of time we might get into this turf battle. So it is very, very important for all of us to see how we can consolidate the gains we have made. And one way is that, this would be my request to all the young interventional nephrologists, including me, that we should try to get this training incorporated into the DM program. Some of us should be in the academic centers, try to incorporate these skills into the DM nephrology residents, so that tomorrow there shouldn't be any question of training. And recently I had a very challenging experience, like one media personal had called me, and he was asking whether your course is NMC recognized or university recognized. All this in spite of completing 10 to 12 years of interventional nephrology practice. And these things can definitely pop in. So it is very important for the youngsters. My request would be to maintain their logbooks properly, get them signed by the trainer under whom supervision they have trained, and most importantly, try to maintain a good relationship with all your colleagues. So these kind of things can always pop in. Someone who wants to stall your progress, or for whatever reasons it is, you can be questioned by multiple people. So I think as a society, it is all our responsibility to ensure whatever gains we have made should be streamlined. And then second thing, sir, of late what I have been seeing is there has been urgency in starting the procedures. Some people with 1 month training or observership, all of us are aware about the Kruger's curve. You know, After a very small initial training, you start feeling that you know everything and you start doing procedures. So I have noticed some of the youngsters, they want to start doing procedures without proper training, which again can be challenging in the long term. So as all of us know, this one in an ideal world, we would want people to get trained for 1 year, because that kind of consolidates your knowledge, and you'll be a full-fledged proceduralist or interventional nephrologist the moment you finish the course, or minimum 6 months. So in an ideal world, it should be 1 year or at least 6 months. But in certain academic institutions where there is a lot of caseload, and they might be finding it difficult to take leave and come already in faculty positions, we are trying to accommodate them for 3 months. But at any point of time, if you want to start a full-fledged program, if you want to run a good program, I think it is very important that you have a proper training. So that would be my only suggestion, that don't be in a hurry. Considering the long term, 6 months or 1 year is nothing when you compare the long term ratifications. So I think this is what I would suggest, sir. But I think we have made great progress, and the day is not far away where we'll be having at least 300, 400 interventional nephrologists in our forum, sir.
Right. Then, I think next I thought I'll call Hardik and Manas. See, your centers have both DM program or Depend B. Then we have this fellows who. What happens there? Who gets involved in intervention? How do you satisfy all of them?
Yeah, so currently we have two 1 year fellows who will be doing the university fellowship program, and then we are also part of the ISN training center. So we have a 6 months program. So our caseload is adequate to provide training for all three of them, sir. And obviously, our first priority is our interventional nephrologists who have dedicated themselves for 1 year. I think it's a huge sacrifice they have made. So our first priority is always 1 year fellowship program. But I think the caseload is such that even the 6 months ISN fellow is also getting. I would like to believe at least that he's also getting adequate training. He or she gets adequate training. That is a thing, sir. I think all our centers have enough caseload to train the trainers, and we always believe in the thought process, sir. So what I believe is that you can be a proceduralist or an interventional nephrologist. I think a proceduralist, anyone can do the procedures, even the cath lab technicians. If they spend adequate time doing this hands-on training, they will become proceduralist. But that is not our intention. Our intention is to produce nephrologists who think and do the procedures. So this interventional training should make them good clinical nephrologists, and that knowledge should make them a good clinical nephrologists with these procedural skill sets. So I think all of them get adequate training at our institutes.
Hardik and Manas, in your centers, Nadiad and SGPGI, your DM students, do they get trained in all this? The regular DM candidates?
Hello.
Hello.
Yes, sir. Uh, can I speak first?
Yes.
Uh, sir, unlike Dr. Girish and Manas Center, we don't have a too larger volume. Like we do 2 to 3 procedure in a week's time. But we do involve our own residents, and by the end of third year, they are at least used to do the punctures hardware, which is more important, and the thought process. uh, Very few of them, like those who are interested in do continuing, so then if they get interested more, then they start doing their on their own at the end of third year. So I think yes, they do get some exposure. Few of them get interested and they are also getting trained. But unlike SGPGI and INU, the volume is not so large, so we can accommodate full intervention training. But yes, all of us, all of our students, they are once they pass out from here, they do when to intervene. And out of 25%, or like out of four every year, we what we got, one of them is do start doing intervention once they go out. That is what the status at present with us. But I think INU and SGP, I don't think the numbers will be so large at every places. But yes, if they do get constant exposure over 3 years, then few of them will eventually go and join the field. Not all of them is going to join the intervention field.
Yeah. And it may not be always the number of cases, how much you accrue knowledge or
Yes, yes, yes.
from a single case. Because we have seen people who are with great legends, surgeons or physicians for years and years, but the assistant may not be even half as good as the chief at the end of 10 years also. But whereas there will be others, who are able to accumulate their capacity in a short time.
Yes,
So,
but thought process develops during their
yeah,
training only, because what happens, even if you're not doing intervention, but if you know when to
yeah.
intervene and you refer your patient on correct time, that is again more important.
Mm.
That development happens during their training.
Manas?
Yes, sir. Only thing I wanted, I agree with most of the points with Dr. Girish and Hardik. We at our place means like we will allow our residents to do most of the procedures, and only endovascular they will assist. Usually they are not the primary operators. Otherwise, other intervention procedures, AV fistula creation, pump cath insertion, PD catheter insertion, they will be doing independently by third year. So we have basically set a bar that if you want to do endovascular procedures and little advanced procedures, central veins, then you have to dedicate another 1 year, so that you will be doing some little complicated AV fistula creations, AV grafts, and other difficult brachiocephalic BCV cannulation, IJV means like other things. So like we prime them for the most of the procedures, so that after passing off from here after 3 years, they'll be doing 80% of the cases. But for the 20%, we ask them to, if you want, you can join. So that's the basic plan,
Yeah.
sir.
Yeah. So important thing is they should be taught which case to take up, and more importantly, when to stop or give up when they are at some procedure.
Yes, sir. Yes.
Complications. I think with that, Deepak, you
Yes, sir.
can
Ah,
show your maiden case.
So so this lady had a left brachiocephalic AVF, which is now 4 years old now, And she had one access failure left RC fistula that was like before the first initial 2 years. So the initial clinical condition for which she came was basically she had a prolonged decannulation bleed. So the bleed used to be there for like 6 hours after the dialysis, and the staffs used to have tough time pressing over the fistula for quite long. There used to be frequent venous alarms, and she used to have the persistent high venous pressures. So venous pressures usually used to be high around more than 150, and it used to go up to 230 and up sometimes. So that time we did a scan which was showing a access flow of 450 mils per minute. So ideally the access flow should be around 600 to 900. So we examined the patient, and she found to have a significant pulsatile AV fistula with a weak systolic thrill at the juxta-anastomotic segment, and there was absent collapsibility on arm elevation, and there was a palpable thrill at the subclavicular area. However, there was no any limb swelling at this point. So this is how her fistula looked. There were two cannulation zone aneurysms. The skin over the aneurysm was slightly thinner there, but there was no any breach, and this is how it looked prior to the intervention. So we did an ultrasound assessment, and just to confirm the clinical findings, and this is how it looked. Actually, the brachial artery flow was around 450 mils, and this is the feeding artery juxta-anastomotic zone, cannulation zone with the A and V site, outflow vein and central veins. So in the scan, the juxta-anastomotic area was having a diameter of around 4.1 mm. The other areas were fairly normal, and at the cephalic arch, there was a narrowing there around 3.1 mm there. The same in the ultrasound as such. So with this, the clinical impression was definitely there is an outflow issue, but most probably it could be a cephalic arch stenosis. So now whether to, because she has a clinical symptom, and whether to treat the lesion, this is one of the protocol which is followed by the Singapore group, where they triage the patients based on their uh, presentation. So this is just to keep the cases staggered, and to identify patients who are really needing intervention, and to avoid immediate thrombosis. So as per this, if there is a significant dialysis clearance, then it needs to be intervened within a week. So our patient had a fairly good flow volume, but there was prolonged bleeding, which is a clinical sign. And definitely she had these symptoms for nearly 3 weeks, and she needed intervention during this time. So before proceeding for intervention, we have to see the basic practices and protocol has to be followed. We have to know the patient's basic issues, whether the patient has any drug allergies or previous history of any contrast exposure, or the patient is going to get a mild sedation. So patient has any allergy to any medications has to be taken into account. So before stepping into the cath lab, we have to know the basic radiation protection procedures, radiation protection protocols. So the procedurist and the surrounding people have to be adequately leaded. So lead aprons have to be put covering up to below the knee, and thyroid cap, and also in some situations if head cover and also eye goggles has to be taken into account. We have to use the upper shield. So normally the upper shield has to be closer to the receiver or the gantry or the eye, which we call. So this is the C-arm, and normally the X-ray tube is at the lower portion, and the X-ray rays are in this direction. So we have to have a proper cover of the lower part also. Some consoles do have this lower shield. So lower shield can be mobile and can be fixed closer to the X-ray source if you are doing retrograde procedures. And it's not only about protecting the procedurist and the people, but also the patient. So specific console settings has to be kept into mind, like decreasing the X-ray pulse to around 3. So normally the peripheral interventions require 3 pulse per second. So most of the cardiac cath labs use pulse around 15. So we have to decrease it to 3, and also to use the concept of collimation. So if the specific area of interest has to be collimate in the sense is to prevent excess scatter, X-ray scatter, so that the area of interest is only exposed, and the patient is not exposed much surroundingly. So all these, if, because we will be using mostly DSA to look for the venous fistulogram, so that time the exposure of X-ray may be quite high. And also we should be aware of the surroundings, the patient on the table, and also the vitals, the blood pressure cuff, pulse oximeter, ECG leads, and also should have a good rapport with our radiographers and also the assistant who is going to assist us. So we should have a proper equipment also, which is like a good ultrasound machine with vascular probe and proper skill to assess the flow volume during procedures to decide on the extent of treatment. So for planning for this patient, we have to properly plan the hardware before starting. So in our case, we used thermo wire 150 centimeter with Bernstein 4 French 100 centimeter, which is a guiding catheter. So it makes things easy to go across the lesion and also have a adequate support. And after the site of lesion is crossed, we exchange to a Teflon wire. So Teflon helps to give a better support for the balloon during inflation, and also helps is quite sturdy to during inflation. So and also the exact balloon which we are intended to use also has to be procured prior hand. Backup plans always has to be kept in mind. We should have a covered stent graft in place, and in event of any complications, and definitely we should even have our vascular or IR backup just in case things are not as expected. So we went ahead with this patient. Initially, we used a 6 French sheath under ultrasound guidance cannulation, 11 centimeter anterograde cannulation. The cannulation was done at the base of the A site. So it is an unusual segment, but sometimes when the skin is quite healthy at the base, we can cannulate in that segment. This is the image of the sheath axis. Here the axis is pointing retrograde towards the inflow. Um, so after proper placement of the sheath, we went ahead with the fistulogram. So this is the fistulogram with DSA was performed, and this is how the V segment, and then followed by the outflow vein, which was quite okay. When the DSA was extended up to the cephalic arch, there was quite a amount of filling defect or stenosis seen with some amount of collateral or veins here. And then the subclavian vein was quite good, and the brachiocephalic and the SVC was normal. So we went ahead with the fistuloplasty. So we initially used a balloon 6 into 60 mm. 6 is the diameter and 66 centimeter is the overall length of the balloon, and inflated up to 16 atmospheres for 2 minutes. So ideally, at the time of inflation, and then while deflating, we have to palpate over the subclavicular area so that to look for any vascular rupture. So once we deflate, and then we did a repeat fistulogram, which showed the dye flow was fairly okay, but the lesion seems to be somewhat present. But the waste was definitely effaced with a smaller balloon. But I did a flow volume assessment to check for the immediate post-intervention flow volume, and the flow volume went up to 1070 from 450. So I was not very sure whether to upsize the balloon, but the flow volume being good, and if the clinical situation is curtailed, then I thought of closing the procedure. So while doing a check fistulogram after a balloon angioplasty, we can keep the balloon distal to the site of interest, so that if there is a vascular rupture, we can even pull the balloon back and do a balloon tamponade for 5 to 10 minutes. So and then later on, I just went on to assess the inflow. So inflow assessment can be done either by two methods: by reflex angiogram, or direct diagnostic cath into the artery and then do a run. So in this by reflex angiogram, we can bring down the balloon towards the sheath, inflate the balloon, and do a gram. However, this was an unusual segment, and the reflex could not be properly performed. So we preferred to flip the sheath and then approach the inflow. And this is how the inflow looked in the fistulogram. The gram was showing some amount of narrowing, good amount of narrowing here. But considering the good flow volume and probably more of a outflow issue, I thought that whether I should treat or not. So I decided to close at that point, and post procedure the fistula was less pulsatile and softer, and she was back on dialysis the next day with a venous pressure of 130 to 150. I'm still monitoring the patient for any recurrence. It's been like now 1 month now post procedure, and venous pressures are still holding. So I leave it to the seniors to educate me on this, like whether I should go for a higher balloon, considering the target flow volume is already achieved, and what to do with the inflow, which is looking quite narrowed, and whether I should do a plasty or leave it as such. Technically, I had a little bit of issues in this for patients. Basically, the cath lab is quite busy all the time, and I we mostly get the slots in the morning, so we start at around 6 or 7 o'clock and finish by 8, so that the cardiologists are not hindered, and or else we get the slot very late in the evenings. So that is one major challenge. And also counseling the patient, the financial counseling, and also the some of the hardwares which are available. So most of the hardwares are easily available, but major constraint which I faced was only the time slot and the counseling the patient and the financial issues. So I would like to know how to deal with these kind of issues. So this is how my first case went, and hopefully she's doing well now. So with this, I would like to know what the seniors feel on uh, this case. Thank you, sir.
Thank you, Deepak. I think we can take some comments right away in this case as well as the queries he has raised.
Yes, so Dr. Deepak, thank you. And at least you have started your cases early after completing your training. So what I understood from your case is your uh, s- identification of which balloon size. And see, for cephalic arch, usually you should proceed with a ultra non-compliant balloon, UHP balloons, like mostly Conquest you should. Even if you are taking six, for initial cases, you should go by 6 or 7 cephalic arch, not more than that. So
Okay.
more than that, rupture may occur, and especially in cephalic arch rupture, it is prone for rupture. And if rupture occurs, then it is very difficult to control. So, so Mustang will not do, because see, Mustang balloon, even they promote it is an non-compliant balloon, but it has some compliance. So this balloon, especially at high pressures or extreme pressures, this will have dog boning effect. So it will injure the cephalic arch more than what you have treated. So take Conquest first. So though Conquest is little means like price is higher, but take a ultra non-compliant balloon. Second case is even if you feel like you have done it correctly, even if you feel that anatomical some constriction is still there, then if clinical examination shows that pulsatility has decreased pre-examination, pre-procedure, or your flow assessment has increased, then you should not be very over aggressive to inflate with a higher size balloon, especially beyond 8, 9. So later in in your career you can do it, but for starting cases I think stick to 6 or 7 maximum.
Okay. Sir.
Not to oversize, especially in a cephalic arch. Cannulation segments you can do, because it is you can easily control them. But cephalic arch and central veins, you should be very cautious at least initial part. Second, that you are absolutely right. Then you should not treat all the stenosis. First, your clinical examination. If it is a prolonged bleeding, and if you think it is an outflow stenosis, first priority is outflow, and never try to eradicate all the stenosis or perceived stenosis what you see in your angiograms. Uh, Only go by the clinical problem. You are here to solve the clinical problem and give the patient a good dialysis, not to eradicate all the stenosis, whatever you look in your angiograms. So juxtaanastomotic stenosis, especially in brachiocephalic fistula, if flow is 1000, no need to treat it. It is protecting the fistula or central veins for high output cardiac failure. So that is definitely. And about logistics, so even if in a private institution, if where there is a cath lab sharing between 3 departments, a nephrologist will have the least say, because you do most cheapest procedures for for your institute or for your corporate. So obviously first will be cardiologist, second will be IR, and third will be IN. So that you have to consider either very early in the morning or late at the night. So that's kind of a adjustment. So if you don't have your own cath lab, and especially cath lab is not required if you have a good siam with good NGO DSA, then you can easily perform 99% of the cases. So try to acquire wherever you are there at least a good siam, not a proper cath lab. That is optional. That is a luxury.
Yes, sir.
Thank you.
Thank you, sir.
Actually,
Thank you.
yesterday I had a case and I could get the slot in the cath lab in Kaveri Hospital only at 10 o'clock. But the issue was the technicians and staff. Then I had to sort of bribe them, telling we'll get special food and all that. I had to spend the 3-4 thousand to feed them.
I'm so
Yes,
generous
sir.
for you,
Same.
sir. So that's why I actually always tell, make a means, like if you are in a good place, and then try to train a staff, or at least nursing staff or a technician or cath lab technician, become a friend with him
Yes.
and give him some importance, and train him so that he will be available by you at any point of time and any and an entire day. So that will be a boon for you. So every time you will not get all the staffs, all the logistics, and I don't think a lot of people are required. Only two people and one kind
Yeah.
of a assistant or additional person who will be able to provide you some sterile things, I mean, things in the sterile field. That is okay. Three persons maximum. So I think it can be like done.
Yes, sir.
Is Shrestha here in the group? No, I saw. I thought because in Biratnagar when I had gone through this ISN trainer program, I found him so versatile in getting things done by he was sharing with the general surgeons and general OT. There the mainly we were trying to do PD catheter insertion and AV fistula. I found him his ability to get things done by the theater staffs and things. He had this knack of talking, and I think we'll have to develop that also whenever we are facilities with other.
Thank you, sir. I'm here. In fact, when you talked Shrestha, I was not sure whether you were talking about me or not. So I kept quiet.
Yeah, I
I'm
was so
attending this
impressed by that.
program.
How you were, juggling, running around, getting things and without hurting them and getting things done. Anyway, I'm glad you are here. Right. Then, any other comments? Because Hemant has a lot of things to tell us.
Uh, may I speak, sir?
Yeah, you can share your story.
Yeah, I'm Dr. Shabazz speaking from Dehradun.
Yes, Shabazz.
So,
Sorry.
yeah, regarding Manas, what he had said was correct. And for the young friends, I would say, please don't create complications. Get yourself better trained.
Yeah.
And if you create complication, it will be difficult to pursue the intervention after all these things. A second thing regarding Dr. Deepak, if you remember Milo's words,
Yes, sir.
beautiful is the enemy of the perfect. Do you remember that?
Yes, sir. Yes, sir.
He used to repeat it so often,
Repeatedly.
and it's
Yeah.
really practical.
Yes.
Don't try to be completely perfect and
Yeah.
absolutely good looking when if it's
Not to
working well,
achieve the
why not
radiological
keep using
perfection.
that side?
Yeah. Yes, sir.
And regarding technical logistic challenges, well, especially in places where there's no dedicated cath lab for nephrology, which are very few in India so far. So better to appreciate what you have rather than cribbing about what you don't have. So if you get a slot, maybe at 6 in the morning or six after 6 in the evening, I think our friends should be utilizing those things rather than complaining too much for that we got don't get slots in the working hours. And lastly, about the manpower, two people will be good enough in the private setup. So one is just assisting nurse and other is the radiographer. So that's how I'm working, having two
Okay.
technical staff. But yes, they have been sticking with me for more than 5 years altogether. So that's a good, those are really good asset to have.
Okay,
There's
sir.
just few comments which I wanted to make.
Yes, sir.
Yes, Hemant, you can share your slides.
Yes, sir.
Deepak, you can unshare.
Yes, sir. Unsure.